morning, everybody. I am Dr. Naresh Kumar, Assistant Professor and Consultant Urologist, Urology, JPMC Karachi. Today we will be discussing the tumors of the kidney, ureter and bladder. So start with renal tumors. So renal tumors actually account for approximately 3% of the adult malignancy. Out of the all adult malignancy, only 3% of these tumors are arising from the kidney. And 51,000 cases annually diagnosed in US, and they have different statistics in different countries, but for US it's 51,000, and more than 12,900 deaths are recorded per year, every year in the US. So as we know, the tumors can be benign and malignant, and the benign tumors including the oncocytoma, endomyelipoma, metanephric adenoma, leiomyoma, lipoma, fibroma, rhabdomyoma, neurofibroma. This is the whole list of the benign tumors, but out of all these tumors mentioned in the list, the two benign tumors are quite more important and more because they are more common, and in clinical practice we see these, although even they are also rare, oncocytoma and endomyelipoma, but we can see, but the rest of the tumors, they are even rarest and hardly you can see in your practice. So start with oncocytoma. It is of unknown etiology and uncommon, quite it's uncommon and account for 3 to 7% of the renal tumors. Only 3 to 7%. Males are affected twice as compared to female and may occur simultaneously with RCC, because RCC itself, RCC means renal cell carcinoma, itself could be multifocal in the one kidney. So it may present together with RCC. So some place there may be RCC, and the other place in the same kidney there could be a oncocytoma lesion. So it looks like a spherical, capsulated, brown, tan colored with contained central scar, and mean size usually it's around 4 to 6 centimeter, usually unifocal, not multifocal, but it may be the part of RCC. So on imaging it looked like multifocal lesion, but oncocytomas are usually unifocal. So mostly found incidentally, 83% with sometime pain or hematuria. So pain is the most common presentation, hematuria is least likely. Investigation, as we say, it's incidentally when we do CT scan for some other reason or pain, or even sometimes ultrasound can give us some idea there is some lesion in the kidney, and when we investigate on the CT has got a typical findings which suggest this could be oncocytoma. It is difficult to distinguish from the RCC on CT scan. As we discussed, it has got a spoke wheel pattern, and so actually in oncocytoma this could be benign and could be malignant. So just on basis on the CT scan we cannot assume it 100% that it is a benign lesion. This could be malignant. So treatment is the same like RCC almost. If lesion is smaller, we can go for partial nephrectomy. If it's bigger one and it's involving the major part or whole kidney, then definitely we will go nephrectomy, go for radical nephrectomy, and then definitely the biopsy will confirm the histopathology, either this is oncocytoma as CT suggests, and either this is benign or malignant. So sometime for very smaller lesion, or if strongly suggestive, sometime we do preoperative biopsy, which if it is confirmed and lesion is smaller, we can manage it with newer technologies like radio frequency ablation, mentioned here is RFA, and other one is the HIFU, which is high intensity ultrasound, high intensity focused ultrasound, which So these actually the newer or investigation treatment and specified, especially used in those patients which are not fit for surgery. Here you can see the upper one is a CT image of the oncocytoma in the left kidney, and the lower one is showing the cut section after surgery. The angiomyolipoma, this is relatively more commoner than oncocytoma, but again it's unusual tumor of the kidney. Here the females are affected more as compared to the males, mostly the middle age, and 20% are associated with the tuberous sclerosis. Tuberous sclerosis is a condition or genetic disorder associated with multiple different types of tumors involving the brain, skin, and other organs. So it may be the part of angiomyolipoma. Tuberous sclerosis and angiomyolipoma may be part of that. So histopathologically, as the name suggests, it is composed of the perivascular epithelioid cells of fat, blood vessels, and the sheath of smooth muscle. So angio means blood, myo means muscle, and lipoma means fat cells. So all these three components are there histologically. So epithelioid cells of fat cells, blood vessels, and sheath of smooth muscle. All these together comprises this angiomyolipoma. Mostly found as incidental finding. Again, it can be diagnosed when patient complaining of the pain. 50% are incidental diagnosis, can present with flank pain or sometimes huge masses, even hematuria. So sometimes they can bleed very heavily, and that could be life threatening in 10% of the cases, and we called it Wanderluck syndrome when this huge angiomyolipoma bleed in the retroperitoneum. So we called it Wanderluck syndrome. So asymptomatic lesion smaller than 4 centimeters should be followed with yearly ultrasound. So if we found it incidentally, you don't need to go for surgery or any intervention, because as we know this is a benign tumor, it will not harm you. But yes, if it is progressing on your follow-up, or if it is bigger than 4 centimeter, because usually we saw the tumor more than 4 centimeter, there is a little risk of bleed, or they can give you pain and disturbance. So in that case we can go for intervention. So larger tumor bigger than 4 centimeter or with bleed should be considered for embolization or renal sparing surgery. So as the name showing this angiomyolipoma, lot of vessels are there, it's a vascular tumor. So preferable treatment option is embolization. So under the radiological guidance, with the help of CT or angiography, the intervention radiologist will embolize the feeding artery, which is feeding that particular tumor, and gradually it will regress. And because we knew that this is the benign tumor, so it will not harm us. But if angioembolization facility is not available, yes, of course we can go for renal sparing surgery, that is enucleation of the tumor or partial nephrectomy. Exceptionally or very rarely in very huge angiomyolipoma, which is very unlikely, but we saw sometimes there are case reports when they found a huge angiomyolopomas and they end up with total nephrectomy. Conservative surgical therapy is necessary because most of the time they are frequently bilateral and multiplicity in case of tuberous sclerosis. So if they are associated with the tuberous sclerosis, they are often multiple or maybe bilateral. Here you can see the typical finding. I will show you here. This is the tumor. You can see the angiomyolipoma, because of the fat content, its density is quite low as compared to other. And look at this, the kidney is showing contrast enhancement, so it's brightened, while this portion, because vessels are there in the peripheral area, so a little bit enhancement is there, but rest of the area is hypodense. So CT density we usually measure in the Hounsfield units. So in Hounsfield units, angiomyolipoma is showing usually around -10 density. Okay, bones are +1000, water is 0, air is always minus, like lung, colon, it's -1000 or always minus. So it's not like air. You can see this is air, jet black. So this is a -1000, but it may be -10, -20, but definitely less than the kidney or other areas. And those angiomyolipomas which are associated with tuberous sclerosis, the newer treatment, they tried with medical therapy also. Certain medicines are given, and although they are not standard treatment, but recently guidelines have shown there are some promising evidence if they have given mTOR inhibitors. mTOR inhibitors are the group of drugs which block the angiogenesis, and if it is given for long time, it helps in regression of the angiomyolipomas. So coming to the malignant tumors in pediatric age group, we have a nephroblastoma, which we know we called it as a Williams tumor, and other one is in an adult population, renal tumor is adenocarcinoma, which is commonly we call them RCC, and then TCC can also be there, because the adenocarcinoma or hypernephroma, it arises from the proximal tubule or renal parenchyma, while if the tumor arising from the inside of the epithelium, inside of the kidney or collecting system, lining of the collecting system, and we know the collecting system is lined by transitional epithelium. So the tumor can arise from that epithelium also, and that will be transitional cell carcinoma. If it is arising from the parenchyma, that will be adenocarcinoma or RCC. And the third tumor, which is rarest maybe, but squamous cell carcinoma, this can also arise from the collecting system in certain specific condition, but it's quite rare. And squamous carcinoma, if arise, it arises from the collecting system, not from parenchyma. Parenchymal tumor is only RCC in case of adult, that is adenocarcinoma, and Williams tumor in case of children. So first we will discuss the Williams tumor, nephroblastoma. This is the name after Max Williams, who first described it. So it is a rare childhood tumor affecting 1 in 10,000 of children. Commonest intra-abdominal tumor of childhood, 20% of all childhood malignancies. 80% of all genitourinary tumor affecting children less than 15 years. Male and female are equally affected, and 10% are familial, means genital, 5% genetic related, 10% tumors are familial, while 5% are bilateral and 75% present less than 5 years of age. So most of the time, if Williams tumor present, it's present before the 5 years of age, but even after 5 years of age, it can be there, and sometimes in adolescence age, in the age of 12, 13, it may be confusing because that age, although this is a common age for Williams tumor, but sometimes RCC can also be there. So 75% of the Williams tumors will develop before 5 years of age. So pathogenesis, it occurs due to the mutation of the WT1 gene, as a WT Williams tumor 1 gene, which is located on the chromosome 11 and 13 and present mostly as a hematuria and hepatitis, followed by abdomen or loin pain or mass. Sometimes children it may present with huge mass. And so all renal tumors usually they have a common presentation. Either they will be present as a mass, as a pain, hematuria, or all of them. So most of them they present with the pain, and the presence of all these pain, mass, and hematuria is least common. So the Williams tumor diagnosed as a first on ultrasound as a mass and confirmed on CT scan with contrast. So ultrasound in urology actually is a first screening tool. So every patient who comes to us with a pain or any pathology, suggest history, when history and examination is suggesting that there is something wrong with the kidneys, so we will go for ultrasound. And if ultrasound is suggesting any mass or any pathology, so if mass especially, then we will go for CT scan, and that should be with contrast. Plain CT scan won't help us. That will give us the least information as compared to the contrast. Contrast CT scan can tell us about the proper size of the tumor and its invasion into the peripheral structures, presence of lymph node, and we can assess whether it is operable or not operable, many things like that. Treatment is definitely the nephrectomy, radical nephrectomy. We have to remove the tumor, and then now there are two treatment options are there. Some people they go for nephrectomy and then followed by the chemotherapy, and another school of thought is that they first do the CT guided biopsy followed by neoadjuvant chemotherapy. Neoadjuvant means before surgery. We call neoadjuvant chemotherapy. So they give neoadjuvant chemotherapy. After biopsy, they give chemotherapy. Once after chemotherapy, tumor regress, and then surgery will be easier. So both approaches are there. In US and UK, approaches is different. RCC is among all the renal tumor, RCC is more common and the main tumor. So we believe in adult, if any patient present to you with the renal mass should be considered as a RCC until proved otherwise. So this is important point. As we discussed, it arises from the proximal convoluted tubules and the most common neoplasm of the kidney. 85% renal neoplasm are RCC, and then 2 to 3% of all adult cancers we discussed already, and that histopathologically are on gross appearance tan colored, lobulated, and mostly they are solid, but sometimes there may be necrosis in the tumor, and which can give us a appearance of cystic lesion in the kidney, but most of the time it's solid. Most common in 6 to 7 decades. Male to female ratio, male has a higher incidence, 1.5 to 1, and this is the 10th most common cause of cancer death. Risk factor I have already highlighted here tobacco, smoking, obesity, and hypertension. These are the main risk factors. Tobacco only contribute to 24 to 30% of RCC cases, and tobacco result in a twofold increase in the risk. Then obesity, of course, hypertension. There are other environmental factors including the exposure or eating cadmium, sodium dioxide, petroleum workers, phenacetin analgesics. This is, and then occupational, leather, tanner, shoe worker, asbestos worker. These environmental or occupational exposure to the leather, tanner, usually they develop TCC. Patient on long-term dialysis can develop RCC. If patient is on dialysis for more than 10 years, then they have a chances of developing RCC. After 10 years of time, RCC develop incidence increases. So acquired polycystic kidney disease, out of which 5.8% of develop renal cancers, and patient with VHL syndrome, that is genetic related condition, von Hippel-Lindau syndrome. So that is also associated with RCC, and in that case, if it is a genetic origin, the lesion is lesions are multiple, or it could be bilateral, which is maybe 2% of all RCCs. So histological variant are types of RCC. The most common one is a clear cell. The next one is a papillary type 1. It's all these actually the types are classified according to the appearance on histopathology. If the cells looks like a clear, they are bigger cytoplasms and smaller nuclei, so the cells appears clear, so they name it as a clear cell. If they have papilla, this papillary type 1, then papillary type 2, which is 10%, chromophobe, and oncocytoma 5%. So we discussed already the oncocytoma can be benign or malignant. So that's why I mentioned here as a malignant also. That could be the variant of RCC also. In clinical presentation, 50% of patients present with hematuria, 40% with pain, and 25% present with abdominal masses. Classical triad occurs in 5 to 10% of the patients, that we also discussed already. So all these finding, hematuria, pain, and mass together present less. So mostly either hematuria or flank pain. These are the two common things, and the third one is palpable mass. Because kidneys are retroperitoneal structures, so renal masses are diagnosed or discovered clinically in a very advanced stage, until unless the tumor is quite big. And smaller tumor cannot be easily appreciated, neither by patient nor by the physician even. So systemic symptoms in case of metastasis 30%. So sometimes patient may present in the later stages or in advanced stages with metastatic. So you can see him, he might have a fatigue, cachexia, anemia, weight loss, hypercalcemia, and liver dysfunction. RCC is also associated with paraneoplastic syndrome because of certain hormone-like secretions from the tumor. So if they secrete parathyroid-like hormones, that can lead to the hypercalcemia, as we discussed earlier. Erythropoietin, renin, gonadotropin. So erythropoietin secretion can lead to the polycythemia, and then renin can cause the hypertension, gonadotropins, placental lactogens, prolactin, enteroglucan, insulin-like hormone, and ACTH or adrenocorticotropic hormone, and prostaglandin identified in RCC patients. So various paraneoplastic syndrome can develop from RCC. So Natural history of disease in 7% are diagnosed incidentally, 45% present with localized disease, 25% with locally advanced, while 30% with metastatic disease. Lymph nodes, metastasis 9% and 27%. Renal vein, because this renal RCC actually extend through the renal vein, and even then IVC, and it in rare cases it may reach into the right atrium also. Distant metastasis to lung 75%, soft tissue 36%, bone 20%, liver 18%, skin and CNS 8%. Diagnostic workup, routine investigation are required for all tumors. Once you investigate, you must need all these routine investigation. You have to see the blood, see the complete blood picture, to see the hemoglobin level, platelets, WBC, because definitely you will be going for surgery. So renal function, of course, yes, serum creatinine, urea, and then electrolytes for the anesthesia point of view, and then LFT, as we discussed sometimes. This could be secondary to LF metastasis to the liver. Liver function may be derailed, or as a paraneoplastic syndrome. Once we do the nephrectomy, liver function may be improved. Urine analysis can tell us about the hematuria. Ultrasound. Now, ultrasound is a first line test for any pain or anything, so that will tell us about the presence of tumor. Then once ultrasound showed that there is some tumor or mass or any suspicious lesion related to the kidney, which looks like a mass, we should go for CT scan, and that CT should be with contrast. We discussed already. Plain CT won't be helpful, because this is a typical of the RCC. When we do CT with contrast, there will be enhancement of that particular mass. Enhancement is a hallmark for RCC. At least 10 Hounsfield enhancement should be there. Bone scan can be done if it is like suggestive alkaline phosphate is raised for metastasis, then it should be done in all cases. Selective cases, when we think that this disease is advanced and chances for metastasis are high, then we should go for bone scan as well. So here you can see the huge solid mass in the left kidney, right, and there is some enhancement, and blackish area or low density areas are the central areas of the necrosis inside the kidney, but the mass is almost solid. We saw angiomyolipoma, it was localized, but here it is huge mass and it's involving the whole renal parenchyma, not like isolated separate mass as we saw in angiomyolipoma. Okay, so every tumor has a staging system, and that is a TNM: tumor, lymph node, and metastasis. Three things we must see, and then this TNM system or TNM classification is classify each tumor differently. So we have a different T's from Tx when primary tumor cannot be assessed, right? This Tx is actually used because we use this in follow-up cases TNM. When you are writing the follow-up, you can write like this. When you don't know about the status of the primary tumor, then you can write Tx, because patient needs workup. That means it's still not diagnosed, or it is not confirmed. You know, this is suppose you saw the tumor on ultrasound. There is a tumor, but you cannot assess properly what is the exact size, invading to the parenchyma, surrounding structure or anything. So you cannot define the T structure. So at least at that time you can write Tx, and when you remove the tumor and he is coming on follow-up and you check it again and you found there is no tumor, so then in that case you can write T0. So these Tx and T0 are for that purpose. But once the tumor is there, you can start with the T1. Tumor is there, but it is less than 7 centimeter. T1A, so T1 is further classified. When less than 4 centimeter, it's T1A, and bigger than 4 centimeter but less than 7, it's T1B, but it should be confined to the kidney. T2, bigger than 7 centimeter but confined to the kidney. 3, extend to the major veins like renal vein, segmental vein, adrenal veins, peripheral tissue, perinephric tissue, but not beyond the Gerota fascia. Okay? So there is a fatty layer or fat between the fascia Gerota and the kidney. So if T3 means either the veins or tumor came out of the kidney but not beyond the Gerota. So this 3 further classify. A means invade to the adrenal gland, perirenal or sinus phase. This classification is little bit changed recently, and this invasion of the adrenal is now considered as a T4. Alright, and the perirenal, as we discussed, and sinus fate is and bulb is the T3A, and T3B is a gross extension into the vein or IVC, and T3C extend the IVC above the diaphragm. So actually when it's extending into the renal vein or IVC, there is another classification for tumor thrombus. So we level it like level 1, level 2, level 3. If it is involving the only renal vein and then IVC below the hepatic veins, above the diaphragm or right atrium, so that will be level 4. And T4 invasion beyond the Gerota fascia. NX node cannot be assessed. N0, as we discussed. N1 metastasis single regional lymph node. And RCC actually metastasized to the hilar lymph node, which lies along the renal arteries and on either side of the renal aorta. So hilar lymph node you can say. So N2 means more than one regional lymph node, and M1 means presence of distant metastasis, which is likely could be liver, could be lung, bones. Right. This is the older classification, stage 1, 2, 3, 4. So practically we use TNM classification, and here just for theoretical knowledge we mention both together, stage 1, 2, 3, 4 as well. So 1 T1, stage 2 is a T2, T3, T2, N0, N0, 3 T3 or T1 with N1 or T2 with N1. Lymph node once comes, so it becomes stage 3, and 4 when tumor is extended beyond the kidney, lymph nodes are positive or metastasis, that is stage 4 disease. This is the diagrammatic presentation. Here I can show you this. Look at this. This picture is quite important. Tumor extending beyond the kidney. This is stage 3. In first stage 1, this is a smaller tumor, subcapsular only. Here it's a bigger one, but still under the Gerota. And this tumor involving the renal veins also. See, this is tumor thrombus going into the renal vein and then towards the IVC, and snake-like pattern. It can go up, maybe into the right atrium. And this is stage 4, involving the colon, adjacent structure. Treatment. So the treatment of RCC, of course, is a surgery. Surgery is the only curative treatment option for RCC. RCC is basically chemo-resistant and radio-resistant tumor. we have very limited options. So surgery is the mainstay of treatment. So according to stages, we can do surgery like a partial nephrectomy or total nephrectomy, total radical nephrectomy. Radical nephrectomy is basically the gold standard treatment for localized RCC with contralateral normal kidney. And the difference between, or we can say the principle of surgery, what is the difference in normal nephrectomy and radical nephrectomy? Normal nephrectomy, when we are doing a nephrectomy for non-functioning kidney related to the benign diseases like chronic pyelonephritis or a stone or anything, we go from the retroperitoneal approach. But in case of tumor, we always go transperitoneally. Why we go transperitoneally? Because in radical surgery, we have to ligate the renal artery first. So if we go posteriorly from the retroperitoneal, approaching to the renal artery directly without mobilizing, without opening the aorta fascia, it won't be possible, because this is the one of the principle. We don't have to open the aorta fascia. First we have to ligate the artery, then you mobilize the whole kidney to take it out, because there are chances of seeding of the structure, and tumors are quite vascular, and if you, some people by mistake ligate the renal vein also, that could be dangerous sometimes, because it has a very high blood flow. We know kidneys are a high blood supply. 25% of total cardiac output is going to kidney. So there are the principles of surgery: early ligation of artery and then vein, of course removal of kidney including aorta fascia. So our approach should be along with aorta, outside the aorta. Normally in non-functioning kidney we open the aorta, but in radical nephrectomy we don't open aorta. Removal of ipsilateral adrenal gland if tumor involving the upper pole or middle pole adrenal gland should be removed. But in case if the tumor arising from lower pole, yes, adrenal gland can be spared, because in the older practice it was a mandatory, but now in lower pole, when we see the tumor is quite far away, we can spare it. But for, of course, for upper pole tumor which cannot be separated from the adrenal, so adrenal should be removed. Regional lymphadenectomy from erosive diaphragm to aortic bifurcation. This is also not a mandatory step, because doing a lymphadenectomy with radical nephrectomy, it won't be of survival benefit. So it can help us for pathological staging, like you can, if the tumor is there in the lymph node, you can label it as a N1, N2, but survival benefit is not there. Okay. And definitely prognosis will be, if in case we found, we can assess the prognosis of the patient, but this is again not mandatory part to remove the lymph node. Nephron sparing surgery means only the tumor can be removed, or partial nephrectomy. It has certain indications, like when tumor involving the both kidney, of course we cannot remove the both kidney together, so we will try to save as much as nephron, so patient can survive without dialysis. Or if there is a RCC in a single kidney, solitary functioning kidney, other kidneys, either the patient might have a nephrectomy for some other reason in the past, or that kidney is not functioning, he has only single functioning kidney and that developed RCC. So we should try to save the kidney function, and we will go for partial nephrectomy if possible. Now when we are doing a nephron sparing surgery or partial nephrectomy, we should not forget the principles of oncological surgery. So what I mean to say that if we are in order to save the kidney or some nephron, and we do the partial nephrectomy and save the left the some tumor there, what will happen? The disease will recur. So the our primary goal is there that we should remove the complete tumor, because that is malignant. So tumor should be completely removed. So planning for partial nephrectomy should also only be done when it is possible that tumor can easily be removed and the rest of the kidney can be saved. And if the kidney is small and you think that we cannot save the kidney, we don't have choice. We cannot leave the tumor behind. Unilateral RCC with contralateral kidney under threat of future function, there are certain indication for nephron sparing surgery, medical diseases like stone disease, diabetes disease. Both kidneys are already at risk. So tumor less than 4 centimeter with a normal opposite kidney, again yes, we can do partial nephrectomy, and the 5-year survival rate 75 to 85% if it is it has a good survival rate even with partial nephrectomy. And local tumor recurrence of 10% is reported. Okay, for the metastatic disease, when the RCC is metastasized, then treatment options are different. We have different treatment modalities. We have surgery, we have radiotherapy, chemotherapy, targeted therapy, and immunotherapy. Now we discussed already RCC. Actually, this is the radio resistant and chemo resistant. Radiotherapy we use in very selective cases. There are only 2 indications to use radiotherapy in RCC, metastatic RCC. One, when there are the mets in the brain, so we can use radiotherapy. It helps. Of course, it will not cure, but it helps. And second thing, when there is a there are mets in bones, and that causing too much pain, can causing pathological fracture. In that case, focal radiotherapy can be given in that particular area. Surgery, yes, it has a significant role in even in metastatic disease. Now surgery in metastatic disease can be done with 2 intentions. Definitely we have to remove the kidney, so nephrectomy. One can be palliative and other one therapeutic. Every patient who diagnosed every patient who diagnosed with a metastatic RCC, we have to see and individualize the treatment option. Nephrectomy with therapeutic intention, we cannot cure the patient with metastatic disease, but there is a one term we use it, cytoreductive nephrectomy. Okay. That is a therapeutic nephrectomy. So we reduce the tumor load as much as possible, then followed by the target therapy. Or palliative nephrectomy can be done when there is a severe hemorrhage, severe pain. Sometimes it helps in controlling the paraneoplastic syndrome as well. When we remove the tumor, the paraneoplastic syndrome like deranged LFTs can be improved, or usually improved. And if there is a solitary metastasis in the lungs, in that case, if expertise is available, it should be removed. Like we have to remove the kidney, and if single metastasis is there, that should also be removed. That could be a therapeutic one also. Metastatictomy means if once we have removed the tumor and patient comes back after the after some time with recurrence in the local renal bed, but there is no distant metastasis. So again, treatment option is to remove that recurrence area. We call it as a metastatictomy, or a single metastatic lesion in periphery, if possible, should be removed. For METs, there are chances of less than 1%. If we remove the primary tumor, the metastasis can regress. But I think this is just theoretical. I didn't saw any case. Palliation for usually they have body pains because of metastasis in the bone, so analgesics can be given. Radiotherapy can be given for the bone and brain metastasis, and treatment will encompass metastatic deposits, and so high dose of radiation and such things we discussed already. Chemotherapy, as we discussed, this is chemo resistant. Different chemo agent has been tried, but there is no promising evidence, so it's overall chemo resistant. Target therapy, this is the mainstay of treatment in metastatic disease, because we know that pathogenesis of the tumor, it is highly vascular tumor, and after the mutations in the genes, they produce HIF, hypoxia-inducing factor, and some other factor which leads to the vascular formation, vascular endothelial growth factors. So there the group of drugs which we call tyrosine kinase inhibitors or TKIs, they help to regress the disease. Previously, we have only immunotherapy for metastatic disease. They were using interleukin, interferon, but once the discovery of these target therapies for a decade maybe, the outcome of metastatic disease is improved. So we have a TKI, sunitinib, sorafenib, and some immunoglobulins like bevacizumab and mTOR inhibitors in a high risk RCC can also be tried, that is temsirolimus. But the conventional chemotherapy is not working, not helpful. Immunotherapy, we discussed interferon, interleukin. Nowadays they are not preferred treatment option. So concluding the RCC is relatively rare but increasing incidence because of environmental factor. Incidence increases, and it is associated with tobacco and some inherited disorders. Surgery is the only curative modality for local and localized disease, and for metastasis surgery has some role. RCC is radio resistant. Radiotherapy has a role in palliation only for bone pain and brain, and for stage 4 disease for have poor prognosis, of course, because of metastasis, but doing cytoreductive nephrectomy and with TKI, it gives a good response, maybe 20 to 30% 5-year survival is there. Without nephrectomy it may be lesser than that, but with nephrectomy and this TKI or target therapy, it increases the 6 to 8 months survival. But recently there are some studies, especially nowadays one Carmina trial was conducted, which shows surgery has no benefit, but that is only single study. Otherwise, standard practice still we go for surgery even in metastatic as a cytoreductive nephrectomy. So coming to the ureter tumors, after the kidney tumors, primary tumors of the ureters, they are quite uncommon. Most of the tumors, they are malignant. Benign tumors are even rare or hardly you can see. And among all these malignant tumors, 91% are being transition cell carcinoma, 8% being squamous cell carcinoma, then could be adenocarcinoma and underappreciated carcinoma, and primary sarcoma account for less than 1%. So ureter tumor actually, we start, ureter is quite bigger structure, tubular structure, start from renal pelvis down towards into the bladder and inside the bladder. Some part of the ureter, distal ureter is intramural, going inside the bladder. So it's all lined by the transition epithelium. So tumor arises from transition epithelium. That's why it's TCC, transition cell carcinoma, is common one. Most of them occur in the renal pelvis, least in ureter. And if it involving the ureter, the lower ureter or distal ureter is more common. 5 to 10% of all urothelial tumors are in the ureter. So renal TCC, as I told you, because the urothelium lying from the collecting system, whole collecting system, calyxes, pelvis, ureter, they have same epithelium. So renal TCC is the most common and extrarenal part of the pelvis, followed by the infundibulocalyceal region. 2 to 4% bilateral uretrically and can be there 2% only. Upper tract TCC after bladder. This is because TCC is considered as a field change. Okay, and all this urothelium lining from calyxes through the bladder, there is a TCC. So once the changes develop, malignant changes develop in transitional epithelium anywhere, it can develop all over. So because this is the environmental disease and usually occurs secondary to some environmental exposure or carcinogenic exposure, which are excreted, as we discussed, excreted through the urine. So it affects all ureter, all transitional epithelium. Now upper tract TCC develops after bladder. Now if somebody who has a bladder TCC, in that case he has the chances of 2 to 7% that he might develop RCC or TCC in the renal pelvis. So upper tract, because dependent area is the bladder. So bladder is the most common. Upper part or bladder with renal pelvis involvement is less, but still 2 to 7% can develop. And if somebody who present with TCC in the renal pelvis or ureter, these patients have a more chances, 15 to 75% to develop bladder cancer also, TCC, because bladder is a dependent area. All carcinogens or urine containing these dangerous molecules stays in the bladder. So if someone who develop pelvis TCC is likely to develop bladder TCC, so that patient need follow-up also. Etiology, it could be genetic or hereditary upper tract carcinoma, upper tract urothelial carcinoma associated with hereditary non-polypocytic colorectal carcinoma, because this hereditary TCC can occur in younger population. Otherwise, this is a disease of older age. Environmental, Balkan nephropathy, Chinese herb nephropathy, different chemical compounds are there which can cause irritation to the epithelium, which results in TCC. But almost all are environmental related. Smoking, we discussed, RCC was also common, and here smoking, aromatic amines, and smokers actually excrete aromatic amines in their urine, which causes constant irritation and ultimately end up with TCC in some patients. Coffee relationship with confounded with smoking and analgesic abuse. Phenacetin, this is a analgesic 2-year latent phase we found, and acetaminophen, which is paracetamol, 20-year latent phase we found, arsenic, occupational, 7 years of contact or inhalation to aromatic amines, charcoal, plastic industries can cause TCC. It's more common in 70 kids, rare in childhood, but it can. And males are more common, 3 times as compared to female, because men smoke more male population is smoker and more male population working in industries, so males are more common for this disease. Clinical feature again, hematuria, most common hematuria, gross microscopic, 56 to 90% of patient. Pain, observative uropathy, second most common in flank pain, obstructive uropathy, sorry, because tumor lying in the ureter, it can obstruct the passage of urine, so it can either give you a pain only, or it can present with other features of obstructive uropathy like impaired renal function, sepsis. And sometimes it's discovered incidentally. 15% of cases it's diagnosed incidentally. Investigations are more or less same, routine investigation. Ultrasound would be the initial investigation for the pain or hematuria, followed by IVU or CTU. IVU nowadays we don't do. It was in older days we do IVU, but nowadays IVU replaced with CTU. It will give you a lot of information, the location of the tumor, hydronephrosis, extension in the surrounding structures, and many more things. Advanced TCC, extended renal parenchyma and infiltrating the pattern. However, so just go management. If TCC or if CT scan is not sufficient, or it's not clear about the RC and the tumor in the ureter, or sometimes contrast studies with CTU urography is not possible, then we go for retrograde pyelography. This is a procedure when we inject the contrast from the bladder into the ureter with the help of a special catheter, ureter catheter. This procedure is done under anesthesia, either spinal or GA, with the help of cystoscope. So that will tell us about the anatomy of the ureter. Usually the growth looks like a filling defect, and there can be a sign of goblet sign, or ureter can be seen as stippled. This is another sign for ureter growth. Here you can see this is the film taken during the retrograde pyelography. So in retrograde pyelography you can see this is the ureter, proximal hydronephrosis, contrast is injected from here with the help of ureter. These are the guesses. Actually in fluoroscope, normally in IVP contrast looks white, but in fluoroscope we change it, contrast looks black, and this is the filling defect which looks whiter, or because this is all contrast. This is a distal ureter, so this is malignant structure formed in the distal ureter. So cystoscopy should be done, as we discussed already. Any patient who develops upper tract TCC, cell carcinoma in the pelvis or ureter, 15 to 75% of them they might have a bladder tumor also. So we should do, even the CT scan is not showing any tumor, because smaller tumor can be missed. So we should do cystoscopy to rule out the tumor in the bladder. And if needed, ureteroscopy. On selective cases when CT or retrograde pyelography is not sufficient, we do ureteroscopy for diagnosis purpose. And same time we can do the biopsy with help, or punch biopsy or brush biopsy. TNM staging as for all other tumor, TA1. So basically if the tumor is confined to the mucosa or it's going deeper, when it involves the lamina propria, then it would be T1, then it's muscle, T2, T3 periureteric tissue, T4 adjacent structure, lymph node, or distant metastasis. Treatment: radical nephroureterectomy, because we discussed that TCC is basically the field change. So if it involving arising from this transverse carcinoma arise from the renal pelvis or upper ureter, nephroureterectomy is option. In selective cases, or when facilities are available, or in case we took biopsy before and it's suggesting that disease is a low risk. Low risk means tumor grade is low. We know that there are the grading system for each tumor. It may be well differentiated, intermediately differentiated, and poorly differentiated. So definitely the poorly differentiated tumor would be of poor prognosis and rapidly enhancing and a very aggressive tumor. So if it is grade 1, well differentiated, and TA disease means it's confined only to epithelium, means it's still not invasive. It has not invaded into the deeper structure, lamina propria or muscle. So in that case, we can try endoscopic resections with help of laser, followed by some chemotherapy, local chemotherapy, mitomycin or BCG. They are investigational treatment, they are tried, but not a standard treatment. The standard treatment is a radical nephroureterectomy. So we remove the kidney, because inside of the kidney is lined by transurethral epithelium, and the tumor arises there, so it involving the whole epithelium. We remove the kidney, we remove the ureter and the cuff of the bladder, because the distal ureter going into the bladder, some part of ureter is intramural also. So we remove that cuff of the bladder also together. That is a radical nephroureterectomy, along with all periaortic lymph nodes, which drains along the renal hilum and ureters and pelvis also. In selected cases, as I say, we can try endoscopic or conservative treatment. Segmental ureterectomy can be done, like if the patient is having a single kidney or tumor arising from the distal ureter. In that case, we can try a segmental ureterectomy. So that segment, distal ureter, can be removed with cuff of the bladder, and then if the bladder is bigger one, then we can take a slip of the bladder to anastomose the proximal remaining ureter, or that if the ureter is shorter one, so it can be anastomosed to the other one. But in that case, you may transform the unilateral disease into the bilateral, so it's not preferable option. That's why radical nephroureterectomy is a gold standard treatment. Chemotherapy, neoadjuvant chemotherapy or adjuvant chemotherapy has a very limited role. After surgery, yes, some people they try chemotherapy, some benefits are there as adjuvant chemotherapy, or in case of metastasis disease, chemotherapy has a role, but limited role. Metastatic disease has a poor prognosis. Either it arises from the pelvis or ureter, upper tract TCC. We call upper tract means kidney and ureter. So TCC arises from upper tract has a worse prognosis than the bladder TCC. In metastatic disease, we can't offer a surgery with curative intent. It can be done for palliation, for pain, sepsis, and hematuria, of course. Coming to the bladder tumor, so vesical neoplasm account for nearly 6% of all cancer in the male, the second most common cancer of the genitourinary tract in the male, and fourth most common cancer in a male. In a woman, These tumors account for 2% of all cancer and are most common cancer of the genitourinary tract. Males are affected twice as often as females. This we discussed already why males are more oftenly affected. Risk factors are more or less same for the TCC in the renal pelvis or ureter, same in the bladder. Male is 2.5 times, and age is most common diagnosed in the 8th decade after 70 years, but earlier we are seeing patients in even 40s and 50s. So theoretically, yes, it's usually diagnosed or commonly diagnosed in the 8th decade, but we oftenly seen after 6th decade or 5th decade. Occupational exposure to carcinogens, yes, environmental exposure is there. We discussed already environmental carcinogens. Chronic inflammation of the bladder mucosa. This is important. Chronic inflammation, why it happens? There are certain conditions, like patients who suffer from the schistosomiasis infection. It causes chronic cystitis in the bladder, which ultimately leads to the metaplasia of the bladder, and that causes squamous cell carcinoma, not TCC. Similarly, the other chronic, like some people having a stone for a long time, those people who are living in a remote area or they don't have facilities, health facilities for surgeries or something, and in that case they have a stone for years, maybe decades, they can develop cancer. Drugs such as phenacetin, analgesic or cyclophosphamide, race, blacks are affected more as compared to the white. Radiotherapy, types of bladder tumors, benign papilloma, adenoma, they are very uncommon, very rare. Malignant tumor, most common is the transurethral carcinoma, second most squamous and adenocarcinoma. Squamous cell carcinoma we discuss in case of chronic irritation in form of schistosomiasis or stones, foreign bodies can cause squamous cell carcinoma, or sometimes this chronic irritation can cause even TCC or adenocarcinoma as well. Sometimes adenocarcinoma, because adenocarcinoma arises from the columnar epithelium, and normally we have transitional epithelium, but because of chronic inflammation or constant irritation, transitional epithelium replaced by the either squamous or columnar because of metaplasia. So any cancer can develop, and adenocarcinoma can also be developed in a uricus remnant in certain patients. Symptoms are same: hematuria, lower tract symptom, urgency, frequency, hesitancy. Especially these such symptoms occur when the patient having a carcinoma in situ, or sometimes if they develop obstructive uropathy and huge growth, when both ureters are obstructed or bladder neck is involved, patient may retain or develop obstructive uropathy, so azotemia or uremia can develop. Physical examination usually it's negative, but in case of huge tumors or in case of retention, we can palpate the bladder, or huge solid tumors invading the intra-abdominal wall, we can see the fistulas, vesicoperitoneous fistulas, or tumor can be seen. Some large hard or solid tumors can be palpated by digital rectal examination. For diagnosis always should be made by the history examination and then investigation. Apart from routine investigation, in doubtful cases we can go for cytology while doing cystoscopy. Cytology should be done by barbotage. Okay, so but cytology is least helpful in normal TCC. It has a sensitivity of around 60% in undifferentiated or grade 3 lesions, but otherwise cytology is related with false positive results, so less commonly done. Radiology ultrasound is the basic investigation tool, should be done in all cases present with hematuria. Then IVU, this is the older investigation, nowadays replaced with the CTU. CTU is sufficient, CT urogram. In certain cases when we cannot do the contrast because of renal impairment or some people have a contrast allergies, in that case we can go for MRI pelvis. But if the patient is having renal failure or GFR is less than 30, then again MRI should be avoided. In that case CT is the ideal one. And then cystoscopy. Cystoscopy we kept it at the cystoscopy we kept it in the last actually, because normally if patient present with hematuria we do ultrasound, and if it is showing there is a growth in the bladder we will go for cystoscopy. But in case if it's showing ultrasound is showing high risk disease, very big growth in the bladder, and with upper tract involvement, upper means there is obstruction into any kidney, unilateral or bilateral, in that case we can change the plan and we should go for CT scan first, because in that case there are more chances the disease is advanced. Otherwise we go for cystoscopy, and during cystoscopy when we found the growth, I will show you here. This is typical growth. So actually the TCC or transurethral carcinoma of bladder is classified into the superficial or non-muscle invasive and muscle invasive. 70% of the tumor of the bladder are non-muscle invasive or superficial tumor, and they can be managed with endoscopic resection, which is called as a transurethral resection of the bladder tumor, TURBT. So cystoscopy will help us for the diagnosis, and then we can proceed with the TURBT, transurethral resection of the bladder tumor. So that will be therapeutic, and that will help us also in staging purpose. So once histopathology will be done after resection, the histopathologist will tell us that type of the tumor and its invasion. Either the tumor is confined to the mucosa, epithelium, lamina propria, or involving the muscle. That biopsy is very crucial for further management, because treatment is changed for all stage. If the tumor is now we will discuss the treatment later. This staging is similar, like we discussed the TNM classification. You have to remember this in TNM classification, because we have shortage of time already. It's a very big topic, so I will not explain. We discussed already the TNM is little bit different from the ureter, more or less same. Here I can tell you, see, this tumor in situ is very important in case of bladder cancer. Actually this carcinoma in situ or tumor in situ, this is the pre-invasive stage. That means it has not invaded the epithelium, it's confined to the epithelium, but it's very aggressive disease, because it is undifferentiated G3, grade 3 disease. So, and usually it present with lower tract symptoms, irritating lower tract symptoms, frequency, urgency, urgent continence like symptoms. And then you can see the papillary lesion TA. The disease is confined to the epithelium only. Then T1 going more deeper into the lamina propria, and T2A when it's going to the superficial muscle layer, T2B deeper muscle layer, and T3 perivesical fats, microscopic invasion and macroscopic, T3A and B, and when T4 involving the adjacent structure like the prostate, T4A, and it may involve the pelvic wall that will be T4D like that. So AN is depend upon the lymph node involvement, perissacral lymph node, number of lymph node less than 5, more than 5, size less than 2 centimeter, more than 5, etc. Tumor spread, it can spread directly or it may be spread via the lymphatics or bloodborne. All routes are there: direct seeding, lymphatics, hematogenous. So as we discuss non-muscle invasive tumor, so what treatment is mainly endoscopic. We dissect it and then within 24 hours of the resection we also inject the single dose of chemotherapy that will prevent the recurrence, decreases the recurrence rate, because it's believed as once we are doing resection the tumor cell might settle down. Seedling of tumor can result into the recurrence. So in that case, after resection, once patient hematuria is settled down, we inject 40 mg of mitocin. There are some other drugs also, gemcitabine, thiotepa, but commonly mitocin has been used. So that should be injected into the bladder, preferably within 6 hours, but can be used within 24 hours of surgery. So that reduces significantly. Even nowadays there are studies. Simple normal saline washing can also reduce the recurrence rate. And then after resection of the primary tumor, we follow the patient with non-muscle invasive tumor with cystoscopy at 3 months. If there is 3 months recurrence, that means the disease has more aggressive behavior. If there is no recurrence at the first 3 months, then it means that disease will have a good prognosis or slow progression. So follow-up should continue till 5 years at least, and if any time he develops recurrence of disease, that follow-up will start from 0. So many patients they can develop, then if in case he is recurring or developing the disease again and again, we can go for some other options like resection, and then mitomycin can be given for 6 weeks, and even if it's not working and he is developing recurrence, then we can try BCG as immunotherapy. BCG has a double role. In high risk non-muscle invasive means the disease is not invading to the muscle, it's confining to the mucosa or lamina propria. It's non-invasive, muscle is not involved, but it's aggressive, means the grade is higher, G3. So that disease is also very aggressive. So in that case, after TURBT, we prefer to give a BCG. BCG not only prevent the recurrence, but it slows or prevent the progression of the disease. Progression means it will not, suppose at that time it's TA or T1, it will not go to the T2 or muscle invasion. And even in non-muscle invasive disease, if it is not responding to the BCG, mitocin, and it's coming again and again, then we can go for surgery, that is a radical cystectomy. In muscle invasive, when we found it, the biopsy is showing that muscle detrusor, proper detrusor muscle is involved. The treatment option is radical cystectomy with urinary diversion, because once we remove the bladder, we have to give some sort of urinary diversion, and common diversion is ileal conduit. So we make a conduit from ileum, terminal ileum, and both ureter are attached to that ileum, and one end of the ileum is brought outside the body on the right side of abdomen as a ileostomy or urostomy, and then that will be permanent diversion. Patient can have a bag on that. So So radical cystectomy, actually in the male we remove the bladder and the prostate, seminal vesicle, and all the lymph node, pelvic lymph node should be removed. This is the integral part of the definition of the radical prostatectomy. But in the female, the whole uterus, ovaries, urethra, everything should be removed. In the male, if the disease involving the prostatic urethra, then we should remove the whole urethra. But if disease is not involving bladder, neck, or urethra, then we don't need to remove anterior urethra. But yes, of course, prostatic urethra or prostate should be removed. So we discuss in muscle invasive disease, we have chemotherapy or some other treatment option. Nowadays, neoadjuvant chemotherapy means the chemotherapy which is given before the surgery. Once we plan that this patient needs the surgery, and we will give him 2 cycles of neoadjuvant chemotherapy, 2 to 3. The advantage of that cycle is that will regress the tumor, help in surgery, and it studies has shown that it increases around 7 to 10% of survival. Lifespan may be increased. So nowadays, for any radical cystectomy which is being done for T2 disease, definitely radical cystectomy which is done for aggressive non-muscle invasive disease like T1, G3, in that case we don't need neoadjuvant chemotherapy. But for muscle invasive T2, 3, yes, neoadjuvant chemotherapy is recommended. Cisplatin based. Cisplatin is a main drug which the medical oncologist is giving. Cisplatin, methotrexate, and 2 other drugs. Cisplatin based chemotherapy, they give a group of drugs. Adjuvant chemotherapy, normally it has a very minimal role. But yes, in certain cases when lymph nodes are positive after the surgery, the lymph nodes histopathology confirm the presence of tumor, or perioperatively when we found the disease was invading the pelvic wall, in that case they give adjuvant chemotherapy. It has a partial response and prognosis is not good. Radiotherapy, neither in neoadjuvant or adjuvant, after the surgery, is not recommended and not preferred because the complication rate is quite high. Palliative surgery, when patient disease is either advanced, suppose it may be T4 disease involving the pelvic wall, or sometimes metastasis. In that case, simple cystectomy can be done because of hematuria, profuse or intractable hematuria which is not responding to any treatment. We can do palliative cystectomy. So for prognosis, approximately half of the low grade superficial tumors, superficial means non-muscle invasive, will be controlled by transurethral surgery or intracavitary use of chemotherapeutic agents like, as I told you, mitocin, thiotepa, gemcitabine. And following the radical cystectomy, the 5-year survival rate varies with the extent and stage. So basically, the 5-year survival rate after radical cystectomy, it's all depend upon the stage of the disease at the time of diagnosis. If it is T2 disease, let's suppose its 5-year survival is more than 70%. But if we are doing it for T4A or T3, the 5-year survival may be around 30%. And of course, if it is a metastatic disease, then it's very dangerous and it has a very poor prognosis. The complication of urinary diversion, the main complication, because urine is coming from the ileum, and ileum is a part of gut. It has a absorbing surface. Normally, transurethral epithelium, it is not for absorption, but gut is meant for absorption. So the toxins or urea and other hydrogen ions, they are absorbed from the gut, because we are using different parts of gut for diversion. So there are chances of acidosis, metabolic acidosis. We called it hypercaloremic metabolic acidosis, but actually that subject is beyond your scope. But there are certain complications like ureter obstruction can be there, hydronephrosis, pyelonephritis, because reflux and infection can go up, can cause pyelonephritis. So metabolic complications are quite common, but that's why if we are making an incontinent diversion, so the stay of the urine in the bowel is minimal, the complication rate is less. But if we make a continent diversion, that means the urine will stay into the gut for some time. In that case, complication rate is higher, metabolic complications. So this was all about the tumors of the kidney, ureter and bladder, and quite big, very big topic, but all important things we discussed. And if we meet next time with separate topic, we can discuss in each section in even in much details. Thank you very much.